following episode is brought to you by the American Urological Association. This episode features content from the AUA2026 meeting in Washington, D.C. For more information on how to claim CME credit for your participation or to view faculty disclosures, please visit the AUA University. Support for this activity has been provided by independent educational grants from Pfizer Inc. and Sumitomo Pharma America Inc.
Good afternoon, everybody. I think we'll get started, and we'll let more people trickle in a little bit as they come back from all the various activities that are going on today. So I have a few housekeeping things just to go over before I introduce the panel and tell you a little bit about this session. But welcome to Focus on ADT in the Modern Era of Balancing Cancer Control and Cardiovascular Safety. This is presented by the American Urological Association, and the AUA strives to offer outstanding educational courses and greatly appreciates your evaluations and feedback, so we're continuously improving our programs. I'm going to introduce our faculty. We have Dr. Preston Sprenkle, who's a urologist from Yale, Alicia Morgans, who's a medical oncologist from Dana-Farber, and we actually have Joshua Levinson, who's a cardiologist from UPMC. So that's really exciting to have. I think we'll have a great conversation here, and we'll get into that. So course faculty, Education Council, and COI review work group disclosures are located on the AUA 2026 website if anyone wants to go to that. The American Urological Association would also like to thank the following companies that provided independent educational grants for this educational activity. That's Pfizer, as well as Sumitomo Pharma America. So course evaluations will be available through the AUA 2026. Evaluations are very important. They're read carefully by faculty members and are used for our ongoing needs assessment in selecting core subjects and faculty for future meetings, including focus sessions for 2027. Please be sure to complete your evaluation when you claim CME credits. All right, so we're going to start our panel discussion. Obviously, this is going to be around ADT and cardiovascular risk, and we're going to try to see what we can learn about how we can improve that through a multidisciplinary discussion here. So I'm going to start this off with a little case. For those of us that manage prostate cancer, I think all of us realize that prostate cancer is a very big condition for urologists. We're very familiar with it, and I think those that do manage prostate cancer have been probably giving ADT for years. However, I think since I was a resident many years ago, what we consider ADT and the different ways of providing it has definitely changed, and we're going to get into a lot of that and how we can manage the various side effects of that as well. So Mr. J is a 68-year-old man who presented with a very high initial PSA of 145. He had a biopsy done that showed a Gleason 9 prostate, high volume throughout most of the cores, and he had imaging that does show diffuse bony mets with pelvic nodes, so we consider him high volume metastatic disease. Now, we're going to talk a little bit about his past medical history as well, which we may not always pay much attention to, but I think here, there are some pertinent findings. So as far as a medical history, he does have hypertension, he has hyperlipidemia, and as noted, he's not on a statin. He's a former smoker, quit about 10 years ago. His BMI is around 31, no previous operations, no prior MI or stroke. He's otherwise healthy, and medications only are amlodipine, and does not take any statins. So we talked a little bit earlier about how ADT has changed and over the years. And Dr. Sprenkle, I would like to ask you, if you don't mind, just giving us a little bit about, what are the different types of ADT, some of the logistics that may evolve in terms of frequency, and your thoughts there.
Sure. So the goal of ADT is really to bring testosterone levels down to as close to zero as we can get, to clinically less than 50. And we have medical options listed here, but surgical castration was definitely something that was done previously. We can then use LHRH agonists. So as we know, Lupron or Gaserelin, these are typically injections and can be given as a depot for someone with widely metastatic disease. We often would start with an anti-androgen in addition to that. So Casodex is one that we would often give a month of lead-in, especially if we used to do this routinely, but I think now the guidance is a little bit more specific. If there is a bony metastasis in a weight-bearing bone, it doesn't have to just be for every man. But more recently, GnRH antagonists like degarelix as an injection or relugolix as an oral agent, those are fast-acting and can be used independently without need for an additional medication. It's kind of went into some of the key differences. So a testosterone flare is one of the things we worry about with the LHRH agonists, as they are stimulating testosterone production initially before the, I guess it's not diurnal, but before the variation in hormonal levels is brought down to undetectable. And in terms of the cardiovascular differences, I mean, that's something that we're really going to focus on. Honestly, that wasn't much. I know it was always kind of nebulous. We didn't really know much about it. We thought there might be a risk, but weren't really sure. And we have always felt that the benefits outweighed any of the drawbacks. And in part, that I think was because we didn't have many different options.
So I think, as you know, Preston, you mentioned, you know, for metastatic patients, I think in the past, the ADT options you just gave would probably be the only thing that we ever give. Alicia, I'll get you to speak to this a little bit, but today I think, you know, now patients with metastatic disease are rarely just, you know, on Lupron or an ADT agent, and there's usually doublet or triplet therapies that are often considered. So if you wouldn't mind, just tell us a little bit about, you know, how you look at doublet therapy, how you look at triple therapy, how you select patients. And I know we're going to go into cardiovascular risk in some great detail, but what are the other risk factors that you talk to patients about when you're considering, you know, ADT and then a doublet and a triplet?
Sure. So we make decisions about doublet and triplet based on a combination of things. One of the most important is going to be the patient's performance status, so their ability to get up, get around, be moving essentially half of their day or more, or at least be awake if they have some mobility issues unrelated to the cancer. And we also then think about whether the patient has prostate cancer that warrants a triplet versus a doublet. So for the most part, patients with metastatic disease don't get ADT alone anymore, just as you said. So it's either doublet or triplet, with doublet being an ADT-AR pathway inhibitor combination, typically for patients who have less aggressive prostate cancer, which is usually going to be patients with recurrent prostate cancer that's metastatic after having prior radiation or surgery to the prostate, or patients who have lower volume metastatic prostate cancer, which is defined by conventional imaging, and PSMA PETs can get things a bit confused, but it's essentially 4 or more bone metastases. High volume disease is 4 or more bone metastases with at least one outside of the axial skeleton, or visceral metastases, and that group would not be the group that we would give ADT and ARPI alone necessarily. It's low volume, so anything less than that would get ADT and ARPI. And that high volume group that I just defined would be one that we would consider for triplet therapy. And those patients, of course, have to be chemo fit. So again, that performance status up and around for at least half of the day. They have to have medical comorbidities that don't make giving chemotherapy dangerous. They have to have social supports that make giving chemotherapy safe. And then more aggressive disease. And the other category for more aggressive disease is de novo metastatic status. So something that out of the box is metastatic inherently makes that disease more dangerous. In all of this, though, cardiovascular disease is a huge consideration. We know when we start ADT alone, we can see an increase in total cholesterol, LDL cholesterol, actually as well as HDL cholesterol within as little as 12 weeks. We also see blood sugars go up. So that's ADT alone. When we start adding on AR pathway inhibitors, we see likely more of this, so compounding all of that kind of activity. And with abiraterone and enzalutamide specifically, we know that people can have cardiovascular risk, especially if they've had prior history of cardiovascular comorbidities. So this absolutely comes into play.
Thank you for that. And, you know, one thing I can say is, you know, for anyone that's actually doing advanced prostate cancer, I think, you know, while this space has definitely become a lot more complicated with newer things, I mean, it's great to see all the different tools that are available to our patients, but that has definitely made differences in the care pathways that happen. So just to provide some context, I mean, Preston, I mean, at your site, I mean, like, there's a lot more integrated and multidisciplinary care. Like, who's doing this for you? Is it mainly urologists? Or are you working with medical oncologists? Do they get referred right if they're metastatic, or is it kind of a combination?
So we work very closely with our medical oncology colleagues, and we will typically initiate the LHRH agonist or GnRH antagonist, and then send them to our medical oncologist for the doublet or triplet therapy, depending at their discretion. I think I do have some colleagues I know do that themselves within urology, but I think that that's probably the minority. I think as things are getting more complicated, and especially administration of chemotherapy, I'm not doing that as a urologist. So.
How about at Dana-Farber, Alicia? How's it there?
The urologists leave all the systemic therapies to us for the most part, but Dana-Farber and Yale are places where we have the infrastructure to do that. I think in so many community practices, and even when I practiced at Vanderbilt many years ago, the urologists would take on more ownership and would start ADT as well as an AR pathway inhibitor, and that's not uncommon. I think that's one of the reasons this kind of a session is so important here at AUA.
And Josh, I'll get you in as well. I mean, we're definitely going to be involved more in the cardiovascular part, but I mean, do you work a lot with the urologists and medical oncologists and helping them to sort out, or part of their pathways?
Yeah, I think locally we have an integrated network, so we have an academic hub and then a very large peripheral network that we could have patients obviously from hours away. So I think there is a difference in practice patterns in the academic hub. It's certainly, I think, predominantly collaboration with our medical oncologists, predominantly starting treatment and having that care pathway. And predominantly from a cardiac standpoint, we're more behind the scenes, and then when people call for help.
Sure.
Yeah.
So actually, this would be a great time if we don't, just to get a sense of who's in the room. Just if you don't mind giving a show of hands, how many people in the room are actually managing advanced prostate cancer right now or see patients with it? Okay, great. And I'd love to hear a little bit about how, and for the most part of this session, feel free, we have mics all the way through, so you can always come up and ask questions. But are you mainly doing it as a urologist on your own right now, or you do work with medical oncologists and more of like an integrated pathways that we hear here? So how many people are doing it on their own as a urologist? Okay, and more with the medical oncologist? How many are sending it right to the medical oncologist when it's metastatic? Still a lot of ownership of things. Great. Yeah. Okay, so I think we were going to go on to talk a little bit more about the cardiovascular standpoint about this, and this was an interesting trial that I actually only heard about the first time when Alicia was in Miami presenting, something for a different conference. So Alicia, if you don't mind, I'm going to switch over to this for the Revolution trial.
Sure.
I can move your slides actually if you just whatever you want.
Thank you. So. I think this slide is actually not the trial itself. This is just to remind us of the underpinnings of the biology of why we think there may be differences between a GnRH agonist and a GnRH antagonist in terms of cardiovascular events. What we do know is that there are androgen receptors involved in endothelial inflammation and monocyte adhesion, and when we are blocking them, we can increase the opportunity for this inflammatory infiltration into plaques and potentially increase the plaque rupture. And when we have an antagonist, we think that there may be different activities there happening than when we are acting as an agonist on the androgen receptor. And there are also differences related to FSH levels. They go up in the setting of a GnRH agonist versus an antagonist. They go down directly and stay down. So let's go to the next slide, please. Thank you. So this came to the forefront of our conversations with the HERO trial, which a number of years ago at this point compared a GnRH antagonist, relgolix, and a GnRH agonist, leuprolide, to understand whether these different drugs would similarly suppress testosterone levels. That was the purpose of this trial, and they did. They actually, relugolix suppressed testosterone just a little bit more than leuprolide, but both of them got well below the FDA parameter of 50 nanograms per deciliter as that castrate level of testosterone. This led to the approval of relugolix for advanced prostate cancer. But in this study, there was a key analysis built in around understanding whether there may be differences in the occurrence of adverse events related to cardiovascular disease, defined as a basket of these major adverse cardiovascular events, and this included non-fatal MI or heart attack, non-fatal stroke, and all-cause mortality in this MACE event. And what we found is that those patients who were treated on this study with relugolix had about half of the risk of these major adverse cardiovascular events than those patients who were treated with leuprolide. This was not a predefined endpoint. It was not the primary endpoint of the study. This was an analysis that was pre-planned and was performed through the normal CTCAE analysis of adverse events. But I think was really thought-provoking and intriguing, and certainly led to conversations around GnRH antagonists perhaps having less cardiovascular risk than agonists. Let's go to the next slide, please. So as I showed you, there was a cartoon before that tried to explain all this stuff. The cartoon was very complicated and actually didn't answer any of the questions of, but what's really happening, right? So the Revolution trial was a trial that just reported last year that I think starts to get us to understand what is actually happening in the level of the vasculature that may be a reason we have seen in various studies, not just the HERO trial, perhaps a difference between GnRH antagonists and agonists in terms of the risk of adverse cardiovascular events. This study was a prospective study of patients who had non-metastatic prostate cancer who were eligible for treatment with radiation therapy with or without ADT, and the clinicians enrolled 94 patients. And these patients either initiated ADT or did not based on their plan with the radiation. And you could see that they were randomized 1-to-1 among those who were receiving ADT to either receive relugolix or leuprolide. And they were followed here with a baseline and then a follow-up coronary calcium, coronary, what? Sorry.
Yeah.
Thank
So
you.
coronary
CTA?
CTA. So yeah, with angiography. Yeah.
Thank you.
Yeah.
Coronary CT with angiography. Thank you, cardiologist.
Thank you. Yeah.
Joshua's our resident cardiologist.
This is nuanced, actually. I think the difference, which we'll get into. Yeah.
Yes, and
yeah.
that's so
Yeah.
he'll be able to talk through that. So we've got two different types of ADT here, and some patients who received radiation alone, and there was a baseline and then a follow-up CCTA, these special coronary CT angiography studies. Let's go to the next slide, please. In this analysis, we could see that between baseline and month 12, for those patients treated with leuprolide, there was a larger development of these, this total plaque volume, which is the top line there outlined in yellow, TPV. There was also a difference with the patients treated with leuprolide having more of this non-calcified plaque volume, and then calcified plaque volume as well. So we can see that this was statistically significantly different when we compared the leuprolide versus relugolix at all of the time points. And the no ADT arm was considered the reference in these. And so here's where I'd like to stop and pass over to Joshua, who's our cardiologist, to talk through what this might actually mean, because again, I think this is there's no clinically significant outcome in this data. This is really, from my perspective, looking at a possible mechanism of difference between these agents. This is not capturing cardiovascular events. This is changes in plaque on a CTA.
Yeah, Joshua, before you get that, I as a middle-aged person now, everyone's telling me to get my calcium score, do all these things. So as you answer this, explain what all this even means.
Yeah, maybe we'll go back one slide just to have a picture, a little bit of a coronary artery. So when we get, for example, a non-contrast chest CT that could be done for any type of cancer imaging as part of a staging scan, hopefully some folks in the room will review it and notice big white plaque, calcified plaque on arteries. That is atherosclerotic plaque that has already been matured and turned into calcium. That, by definition, is not normal. It is so common in folks now, even my age, right, that we consider it normal, but is by definition not normal. We are not born with atherosclerotic plaque, and it starts out as non-calcified plaque at the very microscopic level, and over time we can have non-calcified early plaque. And ideally, if it's there, number one, if we get cholesterol levels very, very low, then maybe we could actually get it to go away. That plaque could reabsorb. And we've seen that. It's rare, but it is not zero, and it's exciting. You get your cholesterol level very, very low, you can have non-calcified plaque that completely goes back to normal. The vast majority of the time, the body sees it, and there can be some response from an immunologic standpoint that leads to bad outcome, where there's very intense atherosclerotic progression, and that plaque can grow and grow and grow and grow. and cause a very narrowed artery, and that can cause ischemia and angina, and there you go. Most of the time, the plaque is present, and the body sees it, and it goes around it, and it sees the plaque, stabilizes it, and gets a nice calcified core, and stabilizes the plaque completely, and that does not, then, the plaque then won't rupture, which is what we want.
Right.
So ideally, we want no plaque in our arteries completely. If you have plaque in your arteries, you want it all to be mature calcified plaque. We want essentially no early unstable plaque. So when we look at this sort of diagram here, this is a diagram of a CT scan with contrast where we can define the lumen of the vessel on the inside as well as the actual artery itself. And they actually run AI algorithms on this. This is actually an AI-based assessment. So in standard of care cardiology, we're not doing that routinely, but it's coming, and it's coming very, very quickly. And as you can see in this trial and others, this is going to be the standard of care. It's very exciting. But I would not say it's yet defined as clearly known to be associated with, or known to be positive in clinical trial outcomes, heart events. But essentially, we give angiography, and we can see both calcified plaque and non-calcified plaque. If you go to the next slide, you can then see a number of different characteristics for arteries, which we know are associated with different, essentially bad outcomes. So total plaque involves calcified plaque and non-calcified plaque. And so any progression of total plaque volume is bad. That is associated with long-term worse outcomes. We know that from a number of decades of trials. Non-calcified plaque is also plaque that is not good, that is associated with worse outcomes. And then low attenuation plaque is very aggressive, rapidly growing plaque. And that also, not immediately, days to weeks, but over months to years, is associated with increased risk of getting a heart attack or having a stent. Wow. So when we see in this trial that one drug shows on the subclinical side a different plaque characteristic, it is very thought-provoking. And worrisome, I think.
No, for sure. And Alicia, again, this was a radiation trial, right? So these are not patients that have been on ADT for decades. I mean, they had been on for
12 months.
Yeah.
12. These were the patients on ADT were on for 12 months.
12 months. Wow.
Yeah.
So, I mean, obviously, very big implications in terms of what you choose and the side effects there. Preston, any thoughts from you on?
Nope.
Can I ask Joshua one more question? So we talked right before this session about how, as I said, this is not cardiac events, but I think the cardiology field is trying to think about, is there a measure of plaque change that might be associated with higher levels of cardiovascular events? And you said that the field is working to establish this.
Yeah, so there are a number of thought leaders who are trying to decide how we define the CT-based characteristics that clearly are associated with worse outcomes. And so, for example, here we see, I believe the total plaque volume difference was something on the order of 60, I believe, I forget the units, but it's millimeters squared. And if you're over 10, that's by definition considered a clinically meaningful association based on these experts. I can share some trials. So, we know that when CT-based characteristics change, they are associated with increased risk. I think in the cardiology literature, we're used to trials that are, to be honest, 5,000 patients, 10,000 patients, where we ask, what's the true mortality difference, or what's the difference in return for a catheterization and a PCI. So this is not yet enough to maybe change outcomes. I mean, I think that's a question that we should ask. But if it were me and I were able to choose and we could talk about, I guess, and I'm curious, sort of insurance patterns and practice patterns and the like, I think we have a number of trials with a similar clinical difference that we've seen, that this is not a fluke result. And then we see now finally some pathway to understand why and how to track it.
And I just want to add, this was a randomized trial, so there was balance in terms of, you can see it on the left side of this table, balance in terms of cholesterol levels, hemoglobin A1C, and cardiovascular risk factors, number of people on a statin versus not on a statin, which is what the randomization allowed them to do, even though there aren't 5,000 patients on this, at least the patient characteristics were balanced. And we are seeing a lot more than a change within that year of 10 and a difference by a lot more than 10. So I just think this is the first time that we in the prostate cancer cardio-oncology world have gotten to see some perhaps biologic explanation for some of the differences that we're seeing.
And to that point, Alicia, so we talked earlier about the HERO trial, I mean, that was really what showed us the difference between agonists and antagonists, but we didn't really have an understanding of why that was happening until this. So how much has this data kind of made decisions for you in terms of what you do with ADT?
Yeah, I think we should also acknowledge in the HERO data, although that was prospective, randomized, it was a larger trial, there had been some other phase 2s with similar suggested outcomes. There was a relatively low number of events in that trial, and so there has always been a question, because this was not the primary endpoint, these cardiovascular events were not adjudicated by a cardiologist, is this a real signal or not? This data is, to me, very compelling because it is prospective, randomized, and a measurement of what's happening in the level of the vasculature. And so this, perhaps even more so, and certainly in addition to the HERO trial, makes me think for those patients who are very high risk that I will favor treatment with relugolix when I have the option to do so, of course acknowledging the insurance challenges that can arise.
And we're going to get Joshua to give us some thoughts from a cardiologist standpoint of what we can do to monitor for these types of things and how we could potentially mitigate it. But before we do that, I just wanted to get some thoughts from the audience. This is obviously very striking data. Any questions, or is there anyone that wants to share their experiences in using one drug over another, or if they saw any differences in their practice or issues with cardiovascular risk after? David?
The difference between agonist and antagonist has been looked at for quite a long time, and a person from your institution, Andrew Shalley, did a lot of work, and we looked at FSH as a parameter, and actually have pretty good data and a visual reason why, and angiogenesis and so forth. And then we have the HERO trial, we have other trials and things like that back and forth that weren't adjudicated, and the discussion continues. I think these data are very provocative and interesting, but when you start dissecting it apart a little bit, when you look at people that were on statins, there isn't any difference, as far as I know, in that. And so that could be a confounding factor. We've done some real, I hate the term real world data, but we've done a couple trials with that about late administration, all the other things. But also in some of the trials, some of the worst results were in men that were on antagonists versus agonists. And why is that after we said all this? And maybe that could be that they were directed towards an antagonist because they had prior cardiovascular disease. But the real issue here is assessing people before they get started and labeling them the ones that need intervention, because the MACE events almost always occur in people that have had some prior history, hypertension, all the other things.
Thank you. Okay, so Joshua, I would love to hear your thoughts on, I think David had a great segue in terms of, looking at this stuff before we even start people on. So what can you educate us on here?
Yeah, I mean, it's such a great comment. I love the conversation. One of the questions I have for especially the urologists in the room, but also on the medical oncology side is, from a cardiovascular standpoint, the idea that we need to do a cardiovascular risk assessment at the time of diagnosing prostate cancer and then treating is something we need to reinforce. I guess the question I would ask everyone in the room is, if someone with prostate cancer gets a heart attack or a stroke, would you be surprised? And I've never met someone who would be that surprised, because the risk is so high. So for example, We have a risk calculator that is now defined and recommended, level 1 recommendation, called the PREVENT calculator. That's used by the ACC and the AHA and really gives a risk of what the average likelihood of getting a heart attack is. And in general, a 10-year risk that is over 7.5% is considered recommending starting point for when you start a statin. So 7.5% from a societal public health standpoint. And basically every man who's over 50, at least 55, probably meets that criteria. I mean, it's not that far off.
Wow.
And so when we then add on folks who have some degree of metabolic syndrome at baseline, that risk is going to be 12, 15%. And we can see by adding any type of ADT, that risk probably goes up as well. And so I guess one of the questions I have for folks in the audience and on the panel is, I'm curious what the barriers are to doing, one, a risk assessment, and two, a treatment strategy. Because I think, to the audience members' point, the major opportunity is probably the recognition that all types of prostate cancer treatment systemically increase the risk of cardiovascular disease, and every patient with prostate cancer is at least moderate, if not high risk. And I can talk a little bit about it. But the nuance between these two agents is nuance.
Yeah.
I think it's probably a real signal, and we can talk about that. But I think all of the patients, regardless of treatment, are going to be moderate to high risk and would benefit.
Yeah, no, I imagine. So, I mean, as a urologist, and I'll ask the panel what they do too, I mean, but I'll admit, I don't think I probably do a very good job of assessing cardiovascular risk, and I don't even really know what that means. Does that mean, you know, it's been a long time since I've taken a blood pressure or a heart rate, but is there certain tests I should be doing? I mean, what are the main thing of what you said, this one criteria that you guys use? So what would you recommend? Or should everyone see a cardiologist?
Right, and that's sort of the question. So I think, you know, there aren't enough cardiologists probably to see every single patient. And I think in our medical oncology world, I'm sure you're overwhelmed as we are trying to get a giant comprehensive assessment. What we look at, the baseline risk, is pretty straightforward. Blood pressure, blood pressure, blood pressure. It's fascinating, but when you look at patients who are diabetic, you get more bang for buck reduction in cardiovascular events when you control their blood pressure than if you control their A1C. And that's been shown in a number of trials. So blood pressure, we want the blood pressure to be less than 130 over 80 on average. And most patients who go to see some oncologist, whether it's a cardio-oncologist or medical oncologist, it probably has that higher number. So that is a red flag if it's over that number. Right. And so even just saying your blood pressure is high, you need to follow up with someone, is a great first step. From a lipid standpoint, every patient should have a lipid panel. When we're born, our LDL, which is our bad cholesterol, is between 30 and 50. Think about that, 30 to 50. The average American has an LDL between 110 and 120. And we used to think that, you know, you had to be the very high-risk familial hyperlipidemia patient with an LDL over 190 to be high risk. But in general, the average American who has an LDL of 115 or 120 has historically died of a cardiovascular event. So average blood pressure average cholesterol and normal cholesterol are not the same thing.
Right.
So our new lipid guidelines really say if you make any atherosclerotic plaque, that means if you visually can see atherosclerosis in your body, your LDL should be less than 100. And if you are someone who has a lot of plaque or an elevated risk, so do that, what's called a PREVENT calculator. You just Google it and you plug everything in and it spits out a number. If your risk is over 10%, you need to get your LDL under 70. And any patient who's had a stroke or a heart attack or a stent, their LDL now needs to be less than 55. Wow. And that's so, and this is all new. Sort of, we've known in the cardiology world, those are the targets we need. The guidelines keep changing, which is great. And so they keep getting lower and lower and lower because we keep showing that if you get them lower, you get less events.
Yeah.
So I think, recognition that someone is, even a statement to a patient, you are exceedingly high risk for a heart attack, you need to see someone within weeks of starting treatment is probably the first step. I suspect it's very hard to do all this in a busy urology practice.
Absolutely.
Yeah.
So, at least, vitals we all have. We'll get blood pressure. We're taught to get bone density scans on patients before we initiated this. Do you think we should be getting these CT?
Well, I guess my question is, do you check, this is a knowledge gap for me, before starting treatment, I presume there's a CT or a PET CT, or not necessarily?
Not always
Not
PETs.
always.
PETs more often. And you can see coronary calcification on the non-con CT portion of a PSMA PET. So this is going to be, for people in the audience, it's going to be unfavorable, intermediate, localized risk and above, where you're also probably going to be getting PSMA PETs. But if it's lower risk, they're not getting them. And I have never seen anyone calculate this off of a prostate MRI. I think we're a little too low.
Yeah, I agree.
Well, you're definitely giving me a reason now to look at the chest on my PSMA PET, so that's very enlightening. I want to talk a little bit about follow-up. Typically, we're seeing these patients every 3 months or so to see their PSA, making sure their testosterone responds. How should we be monitoring for, these kind of cardiovascular risks? Any other? Or why don't you start, Josh?
So I'll share my strategy. So I partner very heavily with primary care and with cardiology, because I don't think that, I was trained as an internist before becoming a medical oncologist, and urologists were not even, which is actually becoming increasingly far away from, where I am in practice now, and that's not where you were trained. So what I would suggest is really partnering with them. Often, I talk about blood pressure in almost every patient visit because it's always high to this point, but patients also are very anxious when they come into medical oncology clinics, and probably if they're expecting a DRE, they're a little anxious coming into your urology clinics as well. So I encourage them, and often their partners have a home blood pressure cuff monitor, and I raise awareness and say, look, your blood pressure is 150/90, that's way out of range. You're not just a little bit out of range. We're aiming for 130/80 or so, 85, and I need you to be lower, so I want you to check a few times a week, and I want you to talk to your primary care doctor about it. I ask when their next primary care doctor visit is. If it's more than a couple of months away, I tell their partner and them that they need to call and make a sooner visit so they can check in about their blood pressure. And then I use that opportunity to say, you're also going to need to check your lipid panel. This is something that you may need to adjust. You are or you're not on a statin on your med list. You may need a statin because you've got calcium all up and down your aorta. So I need you to look into these issues, because cardiovascular disease is the main competing risk for death for you as a person with prostate cancer. Because the same risk factors that put someone at risk for cardiovascular disease are putting them at risk for heart disease. That's basically aging and being a man. So they need to work on all of these things. I don't use the same risk calculator. We have an educational program supported by an NCCN grant using the ASCVD calculator, which is just a different calculator. It's not perfect. I will acknowledge that. But any opportunity to have, and I have my APPs actually using that with them on follow-up visit, where they talk about cardiovascular health and PSA monitoring when the PSA is at a stable point for people who are going to be on longer-term ADT. So this is something that could be introduced into an APP visit. Maybe the same folks who are doing bone health at a later check-in visit, maybe they're doing a conversation around, is your PCP monitoring your blood pressure, your cholesterol, checking on your hemoglobin A1C, that's for your diabetes management, and think about getting on a statin, because many of them need to be on one.
Joshua, anything further to add?
It's exactly the right sort of pathway, and to this point, I think this is the same conversation you're having that I'm having, and we've partnered. So one opportunity is partnering as a team. Think of this as a team, setting guidelines up for what the right expectations are for and they can't be different for a cardiologist to do for a medical oncologist or even a urologist if we're going to take on ownership of this managing risk, saying these are what our expectation is going to be, educating the patients, and then creating that sort of cohesive network as a group, because it is a community, and commonly we'll pass back and forth to patients. So we'll start the conversation, say, you're going to see your oncologist in a month, and please have this data for them to review, and then they'll pass back to me. That way we can all do, because it's a lot of work. But I love the point about home blood pressure monitoring is the standard of care, because we know there's a lot of white coat hypertension that isn't passed along. And so just getting a blood pressure cuff and checking at home allows them to take ownership and doesn't require them to come back to see you in clinic all the time.
So I think we were talking a little bit about, shared decision-making and how we, do multidisciplinary care, and obviously the primary doctors are a huge part of this, but even the patients, obviously have a big part of this as well. So if you can, how, and you said this earlier, Joshua, there's, you can't see everyone that gets put on ADT. So how do you communicate, with the family doctors when somebody's going on ADT? What would you kind of advise us on how to bring the primary care, the patient, the urologist and medical oncologist and oncology care team together around all these other side effects?
So number one is trying to allay the fear, or at least acknowledge that fear. So it's okay to say there is risk here and name that, number one, and there's risk on both sides. And the question that I always ask, and I'll remind every patient, is how do we lower your risk overall? And there's no wrong answer here. So I think a lot of patients are worried that there's a wrong answer. I think I try to remind them and tell them there's so much we can do to lower your risk. Here's how we lower your risk. And we go back to that discussion. And that helps, I think, allay the fears. For many patients, they are truly focused on, I had this case earlier in the week, knowing which drug to choose. And I do think that we can sometimes focus on that. That's very hard to do. And I think in the shared decision-making space, it's not about only saying which drug is right. It's we have to acknowledge there's a cardiovascular risk and there's a prostate cancer risk. And most of the time, I try to remind our patients, get your prostate cancer treated. Get your prostate cancer treated, get your prostate cancer treated. And I'll say that over and over again. And they say, what about my heart? And I say, we will do everything we need to do to protect your heart. Yeah. And then the question is, what does that mean? And we'll go back to the same thing, medical treatment, to help lower all those risks very, very low. So that's how I try to have the conversation, but I'm sure it's different for every case.
I think we're talking about patients who are with metastatic disease undergoing ADT. And there I think it is reasonable to do treatment before, but just to kind of bring up the earlier phase, which is, where we as surgeons and urologists are often seeing these patients and we're evaluating and thinking about cardiovascular risk, it is, well, what is their risk of getting through a surgery? That's our first thing. And so I'm just worried about, are they able to have prostatectomy most of the time, right? And what you're bringing up is really a different way of thinking about it. Like, they're low risk from having an acute cardiac event, where you're just like, okay, they're fine for surgery, but it sounds like we may not be taking into account some of their long-term risk with some of these new guidelines. Do you see those patients as well, or do you have any competing risk advice in that case?
Welcome the conversation. I think so it's really interesting from a system level. For example, in our institution at UPMC, we have had a great change in our perioperative risk strategy to try to take patients who are low risk and not have them go see a cardiologist to get a preoperative risk assessment, because they're not high risk for surgery, and an anesthesiologist can and does do a great job of doing that perioperative risk. And there are a number of standardized guidelines that our anesthesiologists really can follow. So if your functional status is good, they can go see an anesthesiologist and define them as low surgical risk. That being said, and to your point, that one thing that I think the cardiologist or the primary care doctor or the long-term medical oncologist may do differently than the anesthesiologist, but I think our pathways are trying to avoid this risk, is miss that long-term risk assessment to say your short-term risk for surgery is low, go on, but your long-term risk is high. So I think that comprehensive assessment is really important. So for example, in these low-risk prostate cancer patients, the conversation around how do we need to treat your cancer is very different than if you're very advanced metastatic disease, I presume, and saying if you don't treat your prostate cancer, you're going to die. And if we say that to a patient, then it's very easy for me to say, you got to treat your prostate cancer, which is very different, I presume, than a low-risk patient who has a very high. I'm curious, from a med-onc standpoint.
Yeah, I mean, I think that's exactly right. A low-risk patient is going to be on surveillance. And so, again, if there are APPs involved, because I think this, from a urologist perspective, an active surveillance visit, if there's no biopsy, there's no scan to review, it's just a PSA kind of check-in. This is a fast and easy, like, I'm going to catch up on my schedule and then move to the next one. But if some of those visits could be with APPs, there could be a check-in around, hey, let's just talk about your cardiovascular health. And then, I mean, maybe it's a 15-minute, 20-minute visit for the APP, but that person could be tasked with intermittently interjecting this sort of long-term cardiovascular health. This is beyond the scope of a normal urologist, but is in the best interest of the health of the patient from a competing risk perspective.
And Alicia, I know you're the director of survivorship programs, I think, at Dana-Farber, and we have survivorship programs. I'm sure you do too. Can you speak a little bit to? Is there an opportunity to kind of incorporate this into some of the survivorship programs potentially, or?
Absolutely. So for the survivorship program, one of the ways that we try to engage with people with prostate cancer is after they're kind of leaving their urologist clinic. It's after 5 years or leaving their medical oncologist clinic. The focus of the whole visit is there is a PSA check, but the rest of the focus is on cardiovascular health as first, second, and third most important thing, and then on mental health, physical well-being. All of this is also centered on an understanding not just of the drugs, but also on physical activity and diet and engaging people in those lifestyle type changes, because physical activity in particular, I think, should be a focus for many of our patients, can reduce their cardiovascular risk, can help their bone health, their muscle strength, and actually their functional status and independence for the rest of their lives. So that's a big focus of their survivorship clinic, and it is actually part of our we do the ABCDE approach to cardiovascular discussions in our nurse practitioner or PA clinic, and exercise and nutrition and diet are part of that conversation. They're the D and the E in that.
Great. So Preston, I mean, you got, let's say, 4 rooms full. One is a cystectomy. You got another guy with an elevated PSA, and now you got your patient coming back, and we're hearing about lipids, calcium, blood pressure, which is not things we're doing. What do you do in your clinic? Like, how are you doing a bit of this, and what can you speak to, from shared decision making and how you do that?
Yeah, I mean, this has been very educational for me too. I mean, this is not something that I am routinely doing at all. I mean, most of the patients we are seeing are intermediate risk prostate cancer. I'm more concerned about the discussion of, do you need treatment? Is your prostate cancer going to kill you within 15 years? And actually having a better understanding of what their competing risks are has always been a challenge. We do a very poor job of having good nomograms to predict someone's true cardiovascular risk for their overall health. So I'm not having this conversation at the moment, but I think probably need to be considering it and looking more closely at these risk factors. Definitely when referring them, I know they're going to people who have a better understanding and good hands on it, but it's, I think, room for improvement.
Yeah.
I think it's also an opportunity to engage with primary care, because urologists do not have to take on the entire world. I can't do all of this. We engage so heavily with primary care, and many of your patients probably have cardiologists. And you're already engaging with them. So I ensure that my note kind of documents, these are the things to worry about on ADT, and in that special NCCN-supported engagement, we have a letter that goes to providers that's templated that explains ADT causes X, Y, and Z. Please help us make sure that we follow up on X, Y, and Z at this interval. And that's really been a valuable piece of standardized communication, because we cannot, as individual practitioners, take on all of these things, but we can facilitate communication and engagement of our patients with those providers who can own that.
So I know, please.
Hello. I have a question. If Hero and Revolution, they are trials of Regulolix, do you think that we might extrapolate these results to the GnRH? I think that the answer is no, but in this particular case, we are analyzing a similar mechanism of action, so perhaps the answer is, in this case, yes. What do you think about this?
haven't seen data, so I don't usually extrapolate without seeing the data. I think that there are some, Dr. Crawford mentioned that there have been some studies that have looked at GnRH as well and have found some signals, although larger studies, prospective, adjudicated cardiovascular event studies, haven't necessarily borne that out in a prospective way. So I think that the answer is still out there. We don't know for GnRH, but maybe the Revolution investigators could investigate that at some point in time too. I think we just don't know.
Dr. Crawford?
You know, we've known for a long time that ADT has side effects. Anthony D'Amico brought that out years ago. As I grew up as in neurology, the side effects were hot flashes, and we sort of blew those off. Oh, your wife went through them and things like that. Weight gain, loss of libido, and then the osteoporosis. And it's becoming very clear that in a subset of patients, there is a significant risk of mortality to using ADT. And we all know that smoking's bad, being overweight's bad, you should exercise, and we can kick this can down the road. My watch is going off to take my medications, how many steps I have, run, do this and that. Everybody is different, and what turns one person on may not turn another one on. We've been working for the past 3 years on a thing called Prostate Cancer 360, and we got together and bone experts and medical oncologists and cardiologists and everybody else, and we had like 10 things we worked on and a plan to do it. Okay, try to implement it. That's the problem. Okay?
Right.
I don't know if you know Bob Eckel. He's president of the American Heart Association twice. He's my classmate. He was involved with it. The cardiology is big in this whole thing because that's one of the things that kill people. And so how do you get people to adhere to things? That's the issue. You can tell them all you want, but they do it. Well, one of the things we've done, and I want to recognize the unrestricted grant we got from Tolmar, but is dealing with chronic care management. And that's provided with Medicare patients. And they call these patients, they interact with them, and everybody's different. And so we've got to figure it out. What's the platform we use to do something to make? Otherwise, we're going to be kicking this can down the road 10 years from now at this meeting. So we got to do something about it. We got to identify them. Alicia, what you said and others is right. We got to identify the risk and then implement something. So hopefully that will happen.
Thanks, David.
Yeah, please.
Mike Williams from Norfolk. One of the things that we have not talked about, and honestly is not really out there much, but New England Journal of Medicine published an article on the patch trial recently. Estradiol patches demonstrating not only a maintaining or increased bone mineral density, but no issues, non-inferior in terms of castrate stuff going along. All of the other aspect, metabolic dysregulation, pretty much wasn't seen. Mortality is similar across the board to ADT. You know, whenever I was growing up, Steve Friedland talked on Neil Love's Prostate Cancer Update, and he talked about how it's about a race, prostate cancer is, and that the race is whether or not you're going to die of heart disease or prostate cancer, and we're actually causing all the heart disease, you know, with treating the prostate cancer. So the question is, how do we get this out to the world about, you know, estradiol patches and actually using that as an opportunity? Paul Shellhammer is a pretty big proponent, one of our former AUA presidents. He's been on it for the last 15 years of his 18 years of metastatic disease, and he's done very, very well with it. And he's really frail right now, but he's got great, strong bones. So what do you do with all that?
So this one's hard, and then I would love to hear what Joshua says about, this is, you know, very high levels of estrogen that through feedback loops cause downregulation of testosterone production. So yes, good for bone health. I'm not clear that it's good for muscle strength. I don't know that it's necessarily negative, although you have low T, so that's probably causing some atrophy. The challenge that I have, and it's great, no hot flashes, right, because you've got enough estrogen. The challenge here is that people develop gynecomastia, and sometimes that's going to be tender, painful gynecomastia, and it's like at least half of the patients, if not more, and the prophylactic radiation has been less effective than we want. And I still have not started tamoxifen for this. although technically that, obviously that's an option, but most people don't want to take additional medications. I think this gets to what's on the screen right now, shared decision-making. I have some patients on estrogen. I wouldn't say it's most. It's still a minority. And I think that in general, I think this can be an option, whether single-agent ARPI, potentially also an option. The Aramon trial came out at GU ASCO demonstrating a stabilization of hemoglobin A1C, cholesterol levels, muscle mass was the same. So this is a non-castrating version of just being an antagonist on the receptor in certain situations may be reasonable and allows patients, if they can maintain muscle mass, I mean, this may be a way to maintain functional ability and independence. So I think that there's definitely interest. Each trade-off comes with challenges, and regardless of what we use from an anti-prostate perspective, I think this is a sort of a teachable moment or a moment to engage around the #1 killer in the United States, which remains cardiovascular disease, which should still be addressed, even if we're not making it worse, would be my stance.
Yeah, no, it's such a thoughtful question and very exciting to me because I had this exact same question actually on Friday. We had a talk about this exact topic, but for women who'd undergone obviously menopause, and the Women's Health Initiative study suggesting a major increased risk with estrogen replacement and how we've now walked that back. And so there used to be a large black box warning, and as recently as, I forget, is it this year? Maybe this year, just recently that was removed. So I do think that low-dose estrogen replacement in women has been well studied to probably not be at large risk. But even there, the conversation is always shared decision-making, and I don't think we have an answer. But I think the larger point here, and I love the conversation, is we don't have the answer. That doesn't mean we shouldn't ask for the answer as a large community. I think the fact that we have a number of different specialties at the table asking these questions means we need to continue to ask these questions. So, for example, there are a number of oncologic trials where we all agree there's a large increased risk of cardiovascular event, and we ignore the fact that we need to have a secondary outcome of a cardiovascular endpoint, and that we should not as a community allow, right? We need to define as a community what we care about. So there are surgical outcomes that we care about, but if we're going to be involved in some oncologic standpoint, we probably need to be thoughtful as a community to define that. So I think, I don't know what the answer is. My guess is it's going to be quite reasonable to do and safe, but I think people have to say it's worth it from a quality of life standpoint.
I agree. I totally agree. The gynecomastia is the major limiting factor, whether it's surgical or one dose of radiation on one day. In most cases, that solves that. I always kind of say most of my patients that show up have got a BMI of 32 to 35, with a newly diagnosed metastatic prostate cancer. So it's a totally, their risk of that is not as much as what they're worried about in terms of what's going to happen next. But there is data about breast growth. Actually, for estradiol supplementation for trans women, actually, I think at A cup size was more than 75%. That was it, and there's only like 10% that was actually greater than a C. So it's a small number in terms of that amount that's there, but it's still something that's definitely worrisome for most people.
So I know we've focused predominantly on metastatic disease, but there's also lots of situations, especially in the radiation literature, where men may only go on a short course of radiotherapy. And I know we're doing less intermittent therapy nowadays, but there may be some situations we do that. Just wanted to get thoughts on the panel about whether the duration of ADT makes a big difference here. We've talked a lot about, how we should be assessing patients for their cardiovascular risks up front and how we should be monitoring the blood pressure, making sure they're on statins. What if you're only going to be on ADT for 4 months? Does it make a difference?
Yes. Yeah. No, I don't know. I'm hopeful that others on the panel know the answer, but my impression from data and clinical real-world experiences, longer ADT, worse cardiovascular outcomes, shorter is better. So if someone is very high risk, for example, and has the opportunity to consider avoiding systemic therapy, just for the extreme case of, you said short or long term, but about no versus some, I would always say from a cardiovascular standpoint, it's probably safer to have less ADT. I'm curious.
Yeah, so Again, I think that if you have cardiovascular risk factors at baseline, it should be addressed regardless of what's going on with the ADT. And then I agree with Joshua in that if you can get away without using ADT, so there's the Artera MMAI assay that can be used in the setting of intermediate risk disease for patients who are going to be getting treated with radiation. If this says that they have a biomarker negative cancer that is not expected to benefit from ADT, this I think is a huge win for patients. Avoid that, avoid the increased risk of cardiovascular disease, but still address the underlying baseline risk of cardiovascular disease moving forward. When it comes to intermittent therapy, we may see this increasingly coming into even the metastatic setting. There's a study that's going to be reported at ASCO looking at intermittent therapy called ADREAM that will be has stopped therapy for patients somewhere between 18 and 24 months after starting systemic therapy if they got to a very low PSA and then they restart. It is similar to the SWOG trial that was done many years ago in metastatic disease, but it will be starting up on ADT again well before what was kind of the time point for the SWOG study, so starting by 5, a PSA of 5. The challenge here, I would say, is that there have been multiple analyses, including that SWOG study of intermittent therapy in metastatic disease, that suggest that it's the on and the off of ADT that actually may destabilize plaques or cause some permutation of whatever's going on in that hormonal milieu that disrupts plaque stability and then puts people at risk for those events at the time of on and off. And so there were actually more cardiovascular events in intermittent therapy in the SWOG study than on continuous therapy, which is counterintuitive unless you think that the on and off is somehow triggering some events. So I would say there's just so much for us to learn that we can't take anything for granted. At the end of the day, though, anybody with cardiovascular risk factors should have those that are mitigatable, that those that are reversible should be addressed, and all patients should be educated about their cardiovascular risk, just as they are aging men living with that risk factor over their head.
Can I ask, just from a standpoint, do you think that a lifestyle intervention of exercise would lower mortality for prostate cancer? And the background question is, that was shown recently for colon cancer, right? I mean, it's the best study, very exciting, and so I'm curious, sort of.
That was an incredibly exciting study reported, I think, last year at ASCO for patients who had resectable colon cancer, then adjuvant chemotherapy. They were randomized to receive exercise intervention, which was an increase from wherever their baseline level of activity was of 150 minutes a week of exercise versus their standard routine, whatever it was. Those patients who increased their exercise actually had a lower risk of cancer recurrence. This is an amazing achievement, is motivating to my patients, even if it's in a different cancer population. I think that there have been multiple studies of exercise in people with prostate cancer. The challenge with any exercise study is actually getting patients to be randomized to exercise or not exercise, because people either usually are very into exercise or very not into exercise. So that's challenge number one. But if we could overcome that, it would be great. I just try to encourage everybody to exercise, and I use that colon cancer study to try to encourage everybody to meet what the American Cancer Society said as a guidance: 150 minutes a week of resistance and cardiovascular aerobic type exercises, both of those important. Cut it up however you wish, but do the exercise because it's beneficial both from a physical, functional, and mental point of view.
Preston, any thoughts?
That's exciting. Yeah, I mean, I think, as has been said already, we just don't know. But it definitely, I think we want to limit whenever we can. Be very cautious about our use of ADT, whichever one we're using, and clearly feel like we're seeing some signal here with a GnRH antagonist that may be less significant. I mean, if you have a choice, it's making me lean in that direction.
I think this would be a great chance to see if there's any other questions from the group or for the group, or even talking a little bit about shared decision-making, hearing what other people that may be doing differently.
So this is a conversation about cardiovascular, but does cerebrovascular, the same considerations carry over, or should there be some additional assessments? And the second thing, Dr. Crawford's question was a little bit left in the air, because he pointed out that if you treat optimally with statins, then the difference between the agonist and the antagonist kind of disappears. I want to get your opinion of that scenario.
So actually, they were balanced in the Revolution trial. So there was no difference by statin in the Revolution trial, which I just didn't mention. But when it comes to cerebral vascular disease, I would defer to Joshua on that. I think it's probably similar risk factors, similar interventions.
Yeah, I think the answer is yes. I don't think we have as good a trial outcome data, but so far the systemic atherosclerotic events seem to be really systemic, so I think it does make sense. And I agree with the point about statin and randomization here, saying it's, but again, there are very interesting nuances, and one of the larger points here is we have thought historically of atherosclerosis as a cholesterol issue, but that is probably the wrong thing, and there's a large component of this as a purely immunologic or inflammatory discussion, and thinking of it as honestly like a cancer, right? And figuring out ways to lower all those different risks is a really fun part of actually our field, because I think there's a lot more we can do. So, sorry, yes, go.
Dr. Crawford?
Sorry to interrupt again, but there's so many issues here to cover. If you look at the side effects of ADT, most of them occur in the first few months of it. And we've learned that years ago with estrogens and things like that. The difference between the different LHRH agonists and that, some of this may be due with what's called acute on chronic, which Mark Garnick described, where you have these little flares. And that can actually increase your risk, I think, of cardiovascular events. I think probably all patients on ADT should be on a statin. You can argue it, but I think there are pretty strong data to support that. The exercise thing has been around for a long time. That's not new. I don't think there's any question. Your muscle mass, your muscle is your largest organ in your body. It has to do with your immune system, and on and on and on. And I'm sure us that take care of a lot of patients have seen the guys that stay in shape, exercise, have muscle mass, do longer, do better, live longer, have less side effects. And there's a lot of things that go along with that. We've got to really convince people to do that. So I don't think it's known that exercise muscle mass plays a role in survival rate in prostate cancer. I don't think there's any question about it. It's how do we get all this stuff together and motivate patients to do it. And that's what I mentioned, chronic cares, and some people, other things. And some people don't like the word exercise. We need to change that and get rid of that terminology.
Thank you, Dave. So I think this has been a great discussion. I want to thank the panel for such a lively discussion here. And I think, we've heard a lot that, heart disease is still the #1 killer of prostate cancer patients. And we may be doing a lot to even accelerate that. So, I think ADT initiation is a perfect time to do CV risk assessments. I think the Revolution trial that Alicia pointed out there really gave us some pathophysiology about, how this could be happening and how quickly it can actually be happening, And what we said today, ADT class obviously matters, because there may be something, with these antagonists where we may be lowering their risk as one way of lowering a risk in addition to putting them on a statin and getting them to exercise. So obviously early monitoring is critical, multidisciplinary and shared decision-making is critical and improves outcomes and adherence. Thank you, everybody. I want to just thank the panel for such a great conversation, and thank you for your attendance and participation.